Taking things up. A family physician's guide to Parkinson's disease. On this occasion of World Parkinson's Disease Day, I think this is one of the very important topic which I feel will be quite useful for all the general practitioners and family physicians here in Bangalore, bar India. Today, in our topic, what we are going to talk about or learn about is the understanding about what is Parkinson's disease, what are the symptoms of Parkinson's disease, why it is important for us to learn about it, how do the symptoms of Parkinson's disease change over a period of time, how do we diagnose Parkinson's disease, and what are our current treatment armamentarium or treatment options what we have for patients with Parkinson's disease. Finally, before we end, we go up with the common questions what we need to answer for our patients who come to us with various social media videos. That is the special thing which I'm going to cover up, which in the specific context of the issues what we are noticing in the Indian context. So what is Parkinson's disease? Parkinson's disease is a group of symptoms named after a physician called James Parkinson. James Parkinson was a British physician who observed various patients through his clinics and documented those set of features under the medical term called as an essay of shaking palsy. These classical features were so well described by him and hence they are carries his eponym called as Parkinson's disease. Do we have some names in Indian context? Yes, we do have different disorders which were there prior to this, which probably matches the symptoms in relation to Parkinson's disease, such as the term Kampavata in Ayurvedic therapies may probably match to the issues which are related with the Parkinson's-like disorders. So, what happens here? If you can look into the brain, the movement of the body is managed by the brain, and in that, the fine control is managed by the deeper part of the brain structure. This deeper part of the brain structure which marries, we have the pyramidal structure which has the full movements, and we have deeper part which is called as the extrapyramidal system, which manages the fine skill movements or how much and what has to happen. These includes the caudate, the putamen, the globus pallidum. The caudate and putamen together, we call it as the stratum. And then we have the globus pallidus and the deeper part as substantia nigra. These group of structures together modulate the information which is transmitted through the pyramidal tracts to have a finer or a better movements. These are deep nucleic structures, and the most important for us is the substantia nigra in the bottom of this signal system. This substantia nigra, what happens is transmits the signals which controls the way in a good way, I mean it's a better way or a bad way. These chemical includes are primarily produced from the tyrosine, if you remember that. This tyrosine is converted into levodopa using tyrosine hydroxylase enzyme, and this levodopa is further converted into dopamine using dopamine decarboxylase, and that is kept in the tip of the axons. And from there, at this, what you call it as the receptor level, these chemicals are released, and these chemicals, because of this chemical, creates the signal processes which helps in management of various pyramidal tract functions in improve or to reduce. Sometimes when this chemical is related, it is used, and this chemical, what happens afterwards, it gets reuptake and something may be left over down there. And this leftover chemical is either taken by MAOB inhibitor or COMT inhibitors, which is utilized for various. Why I am telling all these things is to understand that why different treatment works for Parkinson's disease down the time. So when this transmission happens, there is a signal going on and helping it. And these dopamine producing cells in Parkinson disease slowly starts getting degenerated, and the number of neurons producing this dopamine, when they start degenerated, the chemical transmission reduces. Hence, there is no better connectivity between the extrapyramidal system and the pyramidal system to have a better effect. So as this effect goes away, the pyramidal system becomes slower and slower, leading to the onset of various symptoms of classical symptoms of Parkinson's disease. So what are these classical symptoms of Parkinson's disease? This is what we want to know. What happens when person develops this set of symptoms? In neurological disorders, we classify them as called as trap features, wherein T stands for tremors. Tremors is something we have fine resting tremors when you're sitting. You have fine resting movements of the hand. What you can see here is called as tremors. R is rigidity. Rigidity is something which you feel stiffness. The body has become more stiffer. The free of the movement of the limbs or the muscles is not the way it is there. A is for akinesia or slowness. It's the time what a person takes to do a given activity. They take more and more time to do those activities. And then we have P, the postural instability. Means you feel that your balance is not so great, your movements are not so great. And these set of features, we call them as Parkinsonism features. Means person who has trap features, T for tremors, R for rigidity, A for akinesia, and P for postural instability, combined together are put under the classification of Parkinsonian symptoms. Among all these features, the most important for us is akinesia or slowness in day-to-day activities associated with rigidity, followed by tremors and postural symptoms. But is every person with TRAP is Parkinson disease? That's not the answer. Because what happens till the treatment options were not available, it didn't make much difference for us what we called each of these patients. However, as the treatment symptoms started to come, we started to notice the differences between each subset of these patients. So what we did was we went a step back, and anyone with this set of trap features, we started to call them as having Parkinsonism. And among them, there are various causes of Parkinsonism are there. The commonest what we know are put under the category of degenerative or aging related disorders and genetic disorders. These includes classical Parkinson disease and disorders which appear like Parkinson disease but have some add-on features. We call them as Parkinson plus syndromes, such as PSP, that is progressive supranuclear palsy, where people have early onset balance issues, eye movements are restricted. Then we have CBS or corticobasal syndrome, wherein people will have cortical sensory deficits leading to striatal hands, or people can have multiple system atrophy, that is MSA, where in addition to Parkinsonian features, they may have cerebellar features, autonomic dysfunctions, and other systems involvement in the brain. Then we have dementia with Lewy body, frontotemporal dementia Parkinsonisms, wherein cognitive features prominent or behavioral features prominent in addition to the Parkinsonian features. These are where the Parkinsonian components could be the prominent features in patients with degenerative or genetic disorder. There are so many other genetic disorders which similarly have Parkinsonism as part of their diseases, but may not be the sole or isolated presentations. Some of these names include spinocerebellar ataxias, advanced Alzheimer's dementias, Huntington's disease, especially juvenile Huntington disease, Wilson's disease, and there are many more other genetic disorders which have Parkinsonism as component of their clinical syndrome or clinical presentation. Because these are important, because they help us to differentiate these patients and to help us to make decision what therapies will help them and how the things may change to them in addition. However, in addition to this degenerative and genetic component, we also have lot of secondary or acquired causes which can present to us with trap features or Parkinsonian features. These include drug-induced Parkinsonisms, autoimmune disorders, acute or chronic infections, metabolic dysfunctions, vascular events. Either it may be acute vascular events or acute strokes or a chronic vascular events, structural brain lesions, nutritional disorders. Uh, these are important because they a lot of treatment where cure can be attained in patients with Parkinsonism. And then people with other diseases which can mimic Parkinsonism include depression or behavioral disorders, especially catatonia, sometimes can be misdiagnosed as Parkinsonism, and functional Parkinsonism can also be present, which we need to remember whenever we talk about different types of Parkinsonian disorders, which we can look. If you take these disorders and look into any perspective, this is where the importance is. There are causes which can be cured, there are causes which can be treated, and there are causes which progresses relentlessly with minimal good symptomatic treatment. This is across any system of disorders, and many times we mislabel and or misinterpret at our general practice level that Parkinson disease is non-treatable disorder. That's not the whole context here. Parkinsonism is a symptom-based treatment similar to our regular other aging related disorders where we keep on giving treatment to improve the quality of life, such as diabetes, hypertension, graying of hair, to name a few. So, wherein the similar level of treatment, similar level of options, however, the acceptance of the terms vary from when we look from the name Parkinson disease as against to other aging related disorders, especially when people come for the first time or when you look at a family physician level, when you look at these disorders, what to expect it as. So, what are the classical symptoms? So, I told that Parkinson disease is a disease of dopamine deficiency and leading to that. So it has various motor symptoms. That's what we're told about. And that is where the what we call it as the contextual presence in a broader perspective holds very good. Parkinson's disease is like a tree what we see. I usually take an example of a seed which grows into root system and then the tree has to grow. I don't know if you have heard about in the Bhagavad Gita, there's a section of what I call as the plant called as Ashwatha knowledge, which keeps on, Ashwatha means which keeps on changing on a daily basis, which is not constant. Means tomorrow, means not constant and keeps on changing. So Parkinson is like a tree what you see. By the time when you see this tree, you are seeing the bigger branches and bigger symptoms. This is how you see it. You don't see so many things what is happening down there. When you see from afar off, you see the symptoms, commonest symptoms. That is what we call it as the trap features, the tremors, the slowed movements, the rigidity or stiffness or loss of balance. When you come closer to the tree, you can see a lot of smaller symptoms such as change in the voice, masked faces, stoop posture, handwriting changes, fine motor related issues, gait and balance related issues can be noticed when you start observing the person more closely, which are well above the ground level, which can easily be appreciated. And when these are easily appreciated, we call them as motor symptoms. Then we have the whole root system which is there below the ground level, which we call it as non-motor symptoms. These includes like autonomic dysfunctions such as dizziness, fluctuations in blood pressure, sexual dysfunctions, gut related issues such as constipations, digestion related issues, sleep related problems in the form of vivid dreams, REM sleep behavioral disorders, periodic leg movements in the sleep, restless leg syndromes, mood related issues such as anxiety, depression, slow in thought processes, cognitive issues over a period of time, loss of smell, and muscle pain, and so on. You take any system of the body, you have a symptom in relation to that. So it's a cluster where you have pure motor symptoms and non-motor symptoms, which together we classify them as whole picture of Parkinson's disease. This is what you need to remember, and not just to see Parkinson's disease from a perspective of tremor, stiffness, and slowness. So now we know what are the classical features of Parkinson's disease and why Parkinson's disease happens. But why it is important to us, especially if it is a rare disorder which is commonly not seen, why Parkinson's disease general practitioners have to know more about that, because Parkinson's disease is an epidemic in waiting. It's going to happen everywhere. As we can see, the global aging is slowly increasing. So our age, the life expectancy has been slowly increasing throughout the world. And most of the time, what we had seen that the young have always outnumbered the elderly. However, as this aging, average age life expectancy is increasing and number of people having children are reducing, we are expecting as time goes by, elderly age population is going to increase. And over the time, this is going to be a bigger and bigger number. As aging increases, the aging related disorders are going to increase. And now we are at a crux where that pandemic or epidemic is going to have an outbreak. So the next set of countries where we are going to have highest number of Parkinsonian disorders includes the developing countries, especially India, China, the Brazil. These are the places where we are expecting a dramatic outbreak, a dramatic increase in number of patients with Parkinson's disease. So we need to keep this point that when we have started to win over treatable infectious disorders, and as the life expectancy is increasing, the aging related disorders are going to become prominent, and that is what will be seeing as time goes by more commonly. So is it truth? Are we at that? Yes, we are at that point now. I can show you some of our publications, what are happening down here in Indian context. I'm going to talk about then more from a global perspective. If you can remember, I think most of you are looking into it. If you can remember, about a decade back or more than a decade back, probably we used to have one or two movement disorder specialists across India who were primarily located at the premier central institutes, and there were most of the things were managed by the neurologists or from the physicians. Now, over the time, what we have seen is the specialists have grown up, and now exclusive Parkinson's disease clinics have opened up, like mine, which have started here in Bangalore. So, which have started up. And these per se indicate that the number of patients which are there are increasing and looking for a specialized case. This is not isolated to Bangalore itself. We are looking at different centers across India. Now we are seeing not only at the major cities across India, we are also sitting tier 2 cities in different states where the movement disorder specialists have started practicing their movement disorders method. We had a major study where we looked into the spectrum of movement disorders cases across India, and almost our two-thirds of our patients who come to us have Parkinsonism as their clinical presentation. This is a work what we did from East India, West India, and South India, that is Mumbai, Kolkata, and Bangalore. And this is could be our one of the pointer studies to understand the spectrum of movement disorders in India. Not only that, in last one decade, we have started to work more aggressively and cohesively across India to work on that. What we have noticed is, unlike Western populations, the age at onset of Parkinson disease is almost like one decade earlier than the Western population. Most of our patients have onset of Parkinson disease between 50 to 55 years, whereas in Western age groups, it all jumps between to 60 to 65 years. And hence, the early onset or juvenile onset Parkinson disease are common in Indian context. We are doing various works at a pan-Indian level, which includes for specialized genetic testing, because we don't know why we are having Parkinson disease. Parkinson disease is limited to certain symptoms, and why we are having it. So bigger genetic projects are happening to understand or profile Indian patients with Parkinson disease and to understand their genetic architectures. And we are also working on their functional aspects, how they work around that. So we know now the symptoms. we know why it is now important for us, or how the why we should know more about Parkinson disease. But now let us dwell deeper how the symptoms of Parkinson disease evolve over a period of time. What we need to see, how it changes as time progresses. I'm going to take to the picture first, then before I coming to the theoretical part of that. The first video, what you're seeing down here, is a person who has just come to me because someone in his family, friends have noticed that his left hand swinging is reduced. You can see that when he's walking, everything is fine. Only he keeps his left hand is slightly posturing. There is no other issues. His professional life, personal life is perfectly fine. This is classical early Parkinson disease, wherein patients don't have any symptoms. At best, minimal symptoms can be appreciated, which don't interfere. Many times they are worried, or family members are worried what is happening now. However, as time goes by, symptoms start becoming more prominent and prominent, wherein they become slower in most of their day-to-day activities. Like as you can see here, their posture changes and they are more dependent, or they require help in small, fine skill activities. However, this is the symptom. You can see that this patient is that first part was without medication. Second part of walking is with medication, wherein after taking medications, his walking becomes much better. And that means they are responsive to medications good enough. But as time progresses further, even though medications are working, they start having slightly unwanted excess movement. The same person, what you can see that there is the neck movements, the hand, you can see that is flickering around. These are called as dyskinesia. These are not noticed by the patients, or sometimes noticed by family members. Usually they are mild, not bothersome, no need to jump and treat. That is the important part. These are all DOPA responsive phase. Then we have phase where the medication keeps on working, but people developing more and more motor fluctuation, where more than when they are on, they have more dyskinesias, and when they are off, they are more stiff and slow. That is what you can see, that severe dyskinesia what this lady is having, which is not allowing her to sit comfortably also. And this is the phase probably when we suggest for surgical therapies. And this is one of the videos of a person who has underwent deep brain stimulation. And you can see that how much dramatically she is better in the post deep brain to almost to an appearance like of an early Parkinson disease. Then, over a period of time, like any of the aging disorders, they develop advanced Parkinsonism where DOPA response might be limited and they're dependent for their most of their day-to-day activities, which is called as palliative care phase. This is how evolution of a patient with Parkinson disease will happen over a period of time. From a theoretical perspective, when we look into that is from what you see from a clinical perspective. From a theoretical perspective, when you look into it, we divide the phases of Parkinson disease into pre-prodromal Parkinson disease, prodromal, early stable, motor complications, advanced, and palliative care. Pre-prodromal Parkinson disease is a phase where patients don't have any symptoms. They just have risks. It may be in the form of genetic risks or environmental risks. So, lot of things are going on at this phase to pick up people at this phase so that early interventions can be done to reduce the loss of dopaminergic neurons. So, there is no symptoms happening here. Then we have the prodromal Parkinson disease. Prodromal Parkinson disease is a phase where people can have certain symptoms which may or may not be associated with classical Parkinson disease. But down the time, we know that they were part of the classical Parkinson, such as loss of smell, sleep-related issues, or vivid dreams, talking in the sleep, shouting in the sleep, or constipation, gut-related issues. These set of symptoms are non-motor symptoms, what we call it as, and they may appear in the prodromal Parkinson disease. Then people will develop motor symptoms. This is the phase what we call it as early stable Parkinson disease. This in early stable Parkinson disease, when these symptoms develop, that is when the diagnosis of Parkinson disease comes into mind. You should remember what I'm showing is x-axis is the onset and the y-axis is the severity of symptoms what is noticed over the duration of time. That is what is happening down there. So the motor symptom develops. Then after some time, what happens? This is the phase when they have symptoms, disability due to Parkinson disease, because of both the things slowly evolve from this phase till the palliative care phase. And this is the phase when there is a good response. What you can see, how the response to medication comes, stabilizes, and slowly you feel that there is not much of response in down the later part of the disease. And currently, all our treatment for Parkinson disease is around this phase, the early stable Parkinson disease, the motor complications phase, and in advanced Parkinson disease, where we have medical therapies, non pharmacological interventions, and then advanced Parkinson disease, such as DBS therapies, can be considered, or other surgical options can be considered in these patients. Then finally, we end up with palliative system or palliative care for people who are bedbound or care relatives is required. This is how an evolution of Parkinson disease during the various phases of its evolution can be noted. So we know now the symptoms, we know now why it is important, how it evolves, but the question is how to diagnose. I told about Parkinson disease, Parkinsonism, and secondary Parkinsonism, how to diagnose it. Diagnose it. Parkinson disease is primarily a clinical diagnosis, means based upon the clinical symptoms. But however, of late there are different testings are coming. Currently, we all of us use, there are different criteria are there, such as the UK brain bank criteria, which is the commonly and standard used criteria for diagnosis of Parkinson disease, and which is primarily a clinical based diagnosis. Then recently a slightly upgraded criteria has come, what we call it as MDS Parkinson disease criteria. Then we are slowly evolving into newer criteria which helps us to pick up so-called prodromal or early diseases. We have two new criteria which have come up. One is synergy. That is, synergy means synuclein related factors, neurological symptoms, and genetic component, or neuronal alpha synuclein disease uh, staging system. Okay. So these are all different criteria are available, and they have their own advantages, and for different reasons they work out better. We are slowly moving into early biomarker based studies so that early pickup can be done. But let us from our perspective, let us say from today's perspective, the most important is the classical features, what I told you. The four classical features: people having stiffness, slowness, tremors, postural changes, you should suspect Parkinsonism, and whether Parkinson disease is the commonest cause for them. What are the red flags? Means if you want to consider this as Parkinson disease or Parkinson-like disorders, is if they have early dementia issues, prominent behavioral issues, early falls they have, poor response to levodopa, and whether they are taking or exposure to other Parkinson, other medications which can cause Parkinson-like medications. Especially what we should remember, antipsychotics we remember, but many times over-the-counter or the gastric medication, the levosulpride what is prescribed causes Parkinsonism, which many times we don't acknowledge. That's what we need to remember as a general practitioner here. Many of these gastric medications what patients take may lead to various movement disorders, including Parkinsonism. Then yes, looking into the imaging for structural lesions, and people should have slow evolving symptoms, not like dramatic occurrence or rapid occurrence of symptoms, and should not be associated with any associated infections, either acute or chronic infections or suspected autoimmune disorders. So if you have these symptoms, you need to red flag it to look it from a more a broader term of Parkinsonism than as a Parkinson's disease. Then, yes, we have smaller lab supportive features are available, such as functional imaging, such as F-DOPA scan and TRODAT scan, which looks into the deficiency of the dopamine content in the presynaptic or the postsynaptic levels to understand what is the deficiency of dopamine. And we now have, with a small subset of patients where a strong family history is there, where genetic testing will help you out, but there are what we call as polygenic risk score, where we know that Parkinson disease is not like one gene, one disease. There are multiple genes are involved. Hence, there are multiple loci in the genes which are act as a risk factors. They have come with 90 high risk loci. Now I think they have recently extended it up to 130 loci. What they're trying to look into is combination of these things. If they are present, your risk to have Parkinson disease is increased or reduced at all. This is called as polygenic risk scores. And we are working on biomarkers such as looking at the synuclein and other biomarkers in the blood or the plasma to understand what is happening down there. So this is how you diagnose a patient with Parkinson disease based upon classical features, and sometimes you use lab as and when required basis. Red flags are kept in mind to look for or to diagnose whether to tell them as having Parkinson disease or Parkinson-like disorders. How do we treat them? So with knowing all these things, the most important is treatment aspect. Many times we feel we give up because we feel that there's no treatment, and that is not the truth, and that is a myth what we know of that. So whole context of any of the aging related disorders, as we know that as aging related disorders comes in, the neuronal loss happens. As neuronal loss starts happening, normal healthy individuals slowly becomes stooped, slow in his day-to-day activities, then becomes wheelchair bound and finally bed bound. This is what happens for any aging related disorders if I don't give a name to the disease. The current context for anything is to make sure that the early phases can be made better. Means you have better quality of life, and so your more dependency phase is reduced as much as possible. This is where all the goals of the treatment which are working on. So we have, as usual, we have two different aspects. One is pharmacological and non-pharmacological. So what do we do? In pharmacology, I'm not going to go in detail to each one of them, just giving a glimpse. There are a lot of treatment options which are available, including levodopas, regular levodopa, and controlled or sustained release levodopas, MAO-B inhibitors, that monoamine oxidase B-type inhibitors, COMT inhibitors, dopamine agonists, which are ergot derived or non-ergot derived, infusion therapies, rescue therapies, anticholinergics, amantadine. These are all the various treatment options what we have or medications what we have for management of Parkinson disease. How do they work? This is a simple flow chart which shows that where these medications work. Dopamine works specifically at the neural transmission level. If you are giving levodopa directly, the inhibitors work by reducing the uptake and improving the conversion of the presence. Dopamine agonists work by stimulating neurons to secrete more dopamine. And this is how at different levels, different medications work to have a better control of whole Parkinsonian symptoms. So many people ask, because many of the time people have seen only the context of people, how do they become better in relation to other therapies. If you look from that, every therapy works. Exercises also work for Parkinson disease. This is a classical patient of Parkinson disease. You can see that she is stiff, slow, classical hand tremors. You can notice that. And also you can see that over a period of time, her slowness is very prominent. The same patient is just given levodopa and we are examining her after some time. You can see that the tapping of the hands, which is so slow on the left hand video, and the right hand video, you can see that so comfortably she is able to tap. And this is within 15 minutes after giving the 15 to 20 minutes after giving the medication. So medications, are especially levodopa, which is a gold standard, dramatically improves clinical symptoms, the slowness, the stiffness, the tremors, and the most of the motor related symptoms become very good dramatically in relation to the utilization of medication. You can see this is the classical, what is, can see that a person who is having classical features of Parkinsonian symptoms on your left hand side, patient who responded to medications on the right hand side, the same patient within 15 to 20 minutes after taking the medication. How this is how medication, I wanted to give an impression of the medication because many times people just have seen surgical and other therapies and many times don't acknowledge the same way the medications have to be acknowledged. So how it happens? So what is this is one classical study what we did across the globe involving 2 continents and about 6 countries and 10 centers. and we collected all patients who have received the Parkinson disease patients, almost like about 3,000 patients whom we looked into it, and we looked how the treatment pattern evolves. What you can see that in this classical, what we interpreted was during the first 8 to 9 years or 7 to 8 years, roughly around 8 years, the levodopa dosage requirement keeps on increasing. And after that, it gets plateaued because they start having other issues becoming more prominent, or there is no much benefits after increasing the medications, or they have more side effects, whichever way you want to look into it. So this is how you need to remember the first 6, 7 to 8 years, the dosage of levodopa keeps on increasing. After that, it almost gets stabilized over a period of time, and wherein we are trying to. This is what we call it as levodopa equivalent daily dosage study or work what we had done. And this we are trying to look into how it varies from Asian versus South Asian versus North American populations. Please try to read this paper if you have some time to understand, or I can talk about it later in detail what all we looked into it. But this is a glimpse what you should remember. So when I showed that graph, what it means, I'll tell you now. So what happens in an early phases of Parkinson disease, you take a tablet, it works for almost for a day or sometimes for more than a day. However, as time goes away, the response is not as long as you expect, leading for you to take medications frequently, once in a day to twice a day to thrice a day. And over a period of time, you start noticing fluctuation. Means you take medication, it works, effect goes away. When it works, we call it as on period. When it doesn't work, we call it as off periods. And as time goes, these responses becomes more erratic. Initially, they are very much predictable. The way having more smooth sinusoidal curve of on and off. Then it becomes more rough waves where you have sometimes you have dose failures, you have suboptimal on medication. Means suboptimal on medication does not give the type of effect they give for every dosages. Sometimes you take medications, you have dyskinesia, that is excess movement because of the medications. These are the different phases what you start noticing, and you have offs. So this is where we call it as motor complications or unstable. You can see as a y-axis from top to down how the evolution of therapy, a response to therapy happens. Where a good response to sinusoidal response to erratic response to more and more dose failure type of a response, what you can see by the time when you come to a advanced Parkinson disease, which is related to various factors, including gut motility, medications, limitations, and other things which play a role in managed to medications. So when we come to these phases, the motor complications and stable phases for medication, we need to have something extras to be done. That is where we have these rescue therapies, where people with Parkinson's disease, when this things does not work out or medications are not kicking in the way they should kick it, rescue therapies in the form of injections are available, where you take it and within few minutes, a person who is almost like not able to move, not able to get up with severe stiffness, slowness, quickly becomes better. Remember the term rescue here. Rescue doesn't mean that symptoms have gone away. Their symptoms are better for a certain quick onset of action for a shorter duration of time. Usually we use apomorphine injections, and apomorphine injections start working in about 3 to 5 minutes, and the benefit lasts for about roughly about 60 to 90 minutes. So in this phase, we want other medications to work to help them out. So this is how, when we try to work on rescue therapies, this is how it works around for a patient with Parkinson disease. So we saw the effect of medications. Now you saw the effect of the rescue therapies when the medications are not working, how it works around. Sometimes this also may not, we need to look beyond that. That is when we call it as non-pharmacological therapies will come into picture. Yes, physiotherapy, speech therapy, swallowing therapy, occupational therapy, cognitive behavioral therapy, relaxation techniques all do help dramatically, and they are required when early onset of symptoms are there, and the amount of symptoms keeps on, effort keeps on increasing over a period of time as times evolve. That's what I wanted to highlight. These are the part of that, including various other therapies, including our alternative therapies such as Ayurveda. Ayurveda, especially, they use mucuna pruriens. Mucuna pruriens is nothing but levodopa, what is being utilized in management, and it does has clear benefits. in relation to Parkinsonian symptoms, in addition to yoga, Unani, Siddha, homeopathy, and the list goes on. In addition to this, other non-pharmacology, we also have other non-pharmacology, which is in the form of surgical therapies, includes deep brain stimulation, classic lesioning surgeries, MR-guided focused ultrasound lesioning, and gamma knife. I'm just going to highlight these things because of late we are seeing a lot of news in relation to these contexts. So what are these? When we look into it, what are the different, when medications are not working, when you list the limitations of medications, and you need to look beyond something. So that is when we need to decide for advanced therapies. So what are advanced therapies? Currently, the classic standard gold gold standard is DBS. So how to know when is your patient ready for a surgery or consider for DBS? Very simple rule of 5 to 1, what we call it as any person who is taking 5 dosages of levodopa in a day, or he has at least 2 hours of off periods in a given day, or 1 hour of uncomfortable dyskinesias, consider for advanced therapies. Very simple. So no need to break your head. Other things, let the treating movement disorder specialist or the surgeon who is going to operate have to break into that. But 5 to 1 is what you need to remember on a daily basis. Person who is on, at least if they are on 5 dosages, or if they have 2 hours of off periods, or 1 hour, any one of them should be sufficient enough for you to suggest them for surgical therapies. When you do surgical, what happens? Like you saw the medications and rescue therapies, what surgical therapies is like putting a pacemaker into the brain, and we stimulate certain part of the structures. By stimulating, we are making them the efficacy of those neurons to be better. Here you can see a person who has undergone DBS, he's switched off, and you can see the so much of tremors in his right hand and not able to move. I am there standing there, I'm going to go and switch on his DBS. As soon as I switch on, you can see that as soon as I switched on, within a second or two, tremors vanished. His movements become comfortable. He quickly started to move. You can see this nicely is moving around. So dramatic effect within seconds, what you can see for tremors and slowness can be noticed after surgical interventions. So what does DBS do? DBS, as I told, is a pacemaker where in the substantia subthalamic nucleus or the globus pallidus interna of the brain, we put the electrodes, and these electrodes are connected to the battery on the chest, and from there electric impulses are provided. These impulses, we control the voltage, the frequency, the the pulse width, and to see that whether they can help you out to improve your quality of life. And by stimulating them, we are trying to help you to have a better quality of life. Which all symptoms? Most of the motor symptoms do get benefited, including bradykinesias, including tremors, including your gait, balance, and non-motor symptoms also can get benefited with DBS. We usually look for at least for about 30 to 40% benefit pre-surgery with levodopa, so that people can have a better benefit after surgical therapies. You can see here, this is a person, the top upper left corner video, what you can see is just he has freshly underwent DBS, and in the programming process, you can see that his slowness, stiffness of the right hand when he's working on that. His finger tapping, hand movement, rotations of the forearm, what you can see there, and it's quite difficult to do it. He is not able to perform the way he has to perform. And then what I'm going to do is, after a few seconds, I'm going to switch it on. And once I switch it on, not more than few seconds, within let us say about 4 to 5 seconds, you can see that how his movements will improve. The person was stiff, slow, not able to move easily, his hand movements, you can see that within a second or two, his finger tapping dramatically improved, his hand movement dramatically improves, and his forearm rotations dramatically improves. So classically, dramatic responses with stimulation alone before and after, what you can say that. I showed you tremors previously, and this is also in relation to bradykinesia, what I'm showing you up here. So it has a dramatic effect on various aspects. But how does it work out? What is its benefit in short term and long term? What we have seen when it comes to in relation to DBS, as I did wrote up recently a chapter for the long-term effects of deep brain stimulations, we were asked to look what affects to the different aspects. In short term, it has good immediate benefit for post-operative DBS. The benefits for mobility and independence are sustained. That's what you need to remember. Medication burdens do reduce significantly in initial phases, but over a period of time, the long-term reduction medication side effects will help you with that. They may have some variable aspects on cognition and mood. Some patients may experience improvement in mood. Some patients may have deterioration also. That's what it means. There may be potential cognitive decline or mood changes over a period of time, which require specific interventions. And overall, from a perception of the health, there's increased satisfaction and emotional well-being from the patient who have underwent surgical therapies for management. DBS is a well-established surgical option and is more commonly available across the globe, and but it's specifically limited to specialized centers. Many countries are where there is a funneling system of medical practice is that there is a referral-based systems, so it helps to go to the right centers. However, it's quite a costly procedure with a lot of financial limitations. If insurance is covered, it's good, but it may not be as easy as it appears. In Indian context, there are insurances which support, but many insurances are, what I've seen is, they are behind the terms and conditions where people get a nominal reimbursement or suboptimal reimbursement for the surgeries, or many times people will not get a reimbursement for them. In some of the states, the government per se is supporting, so they get free DBSs, but limited by restrictions and wait times. That's what we need to remember. And there are a lot of newer technologies which is coming in relation to DBS. DBS works for a long time. I'm not going to show in detail. This is one person who is about now almost like 5 to 6 years after the follow-up and doing still well in relation to the Parkinson disease post-DBS. Now coming to other surgical therapies other than DBS. Other surgical is the classical lesioning, which includes thalamotomy, subthalamotomy, pallidotomy, pallidothalamic tractotomy, and zona incerta lesion. These are all different nucleus where we do go burn that part of the brain and come it. And this is done by different methods. One is classical lesioning, where you put an electrode, burn, and come out of the brain. Then you have MRGFUS, where you use MRI machine as a method. By putting that MRI machine, you stimulate it, and using the ultrasound beams, you burn the part of the brain. So it's a non-surgical technique. Then you have gamma knife. Gamma knife is like a radiotherapy, use gamma radiation to burn a certain part of the brain. So all of them concept remains the same. Methods are different. Outcomes slightly vary based upon those things. So what are the different benefits and limitations of each of these surgeries? I've made this classical table which tells you about the invasiveness of each of these lesioning surgeries, how soon the onset of effect is there, are they adjustable or not. Please remember, all lesioning surgeries, the limitation is non-adjustability. Hence, they have taken a back step because Parkinson disease is an evolving disorder. As things evolve, we need to have something to modulate it. Lesioning surgery is unlikely. The limitation is that you get benefit whatever you got. Down the time, you may not be able to modulate it as the symptoms will change if you want to change anything as such. That is the limitations for that. Unlike DBS, which can be adjustable. And each one of them, like radiofrequency lesioning, focused ultrasound, give an immediate effect. And some of them give effect after some time, like such as gamma knife and because the lesion grows over a period of time. And disadvantages could include no modulations, surgical risk factors, and change in lesion structure over a period of time. Means how the lesion changes over a period of time. And finally, the cost. Currently, if you look into lesioning surgeries, the costliest would be MR-guided functional ultrasound lesioning, followed by deep brain stimulation surgeries, then radiosurgeries, that is gamma knife surgeries, then you have cryo lesioning and radiofrequency-based lesioning surgeries. So now you knew about medications, rescue therapies, and surgical therapies, different surgical therapies and their outcome. So before, we want to know a small flow chart how to manage a Parkinson. Let us say as a general practitioner, we need to know how to manage it, right? So those are all aspects what it goes on, how to decide what has to be done. Very simple. This flow chart should help you out. If you have clinically confirmed Parkinson disease, you need to look whether the symptoms are limiting. Not limiting, reassure, exercises, MAO-B inhibitors if required, follow up. That's what is required. Nothing. Good exercises should suffice. However, if the symptoms are limiting, then based upon their age or severity, you can decide. Mild or younger age, you can consider dopamine agonist, anticholinergics with improvement in quality of life. If that does not help out or they don't tolerate the medications, or people who have moderate symptoms or elderly, the gold standard levodopa will kick into the picture. It remains the primary medications for management, which should improve for every person with Parkinson disease, improvement in quality of life. However, after some time, these patients may also start developing motor complications or may not tolerate, let us say, a very small subset. In that case, we manage these motor complications with addition of other drugs such as COMT inhibitors, safinamide, amantadine, apomorphine rescue injections to make that motor fluctuations better and improvement in the quality of life. In spite of that, if you still stuck with that, then we go for advanced therapies such as apomorphine pumps, DBS, and other therapies will come into the picture with improvement in the quality of life. If as time evolves, the symptoms may become more and more, then finally we end up in the palliative care. This one single chart should give you a concept of how we manage a patient with clinically confirmed Parkinson's disease. But do remember, Parkinson disease is not one disease, one gene. Every person is different. That is where the crux in the management comes. Even though levodopa remains the same, it's not the same for everyone. Hence, what we call is one size does not fit at all. Okay, if you take everyone, it's not like antibiotic. You need to talk to the patient, understand their problems, and modify the medications based upon each person's requirement. Hence, we are moving from generalized therapy to personalized care. We know that Parkinson disease occurs due to various genetics and epigenetic causes, and these genetics and epigenetic causes affect different molecular pathways. Not everything goes to one single pathway for us. Hence, the problem in looking for a cure here. Different immune system, mitochondrial function, all of these different pathways are involved, which finally end up with our trap features. The patients with different molecular pathways and genetics, everyone we are calling that they're having Parkinson disease and we're treating with the same way. What we need to do is segregate them based upon their genetics and molecular pathways and classify them into etiological subtypes. And based upon each one of them, we need to decide which medications is best with least side effects or which may be curative. That is where the personalized clinical medicine will come into management. And this is the phase wherein Parkinson disease is going into it for management down the time. So we got an overall glimpse about what is happening, what are Parkinson disease symptoms, evolution of symptoms. We looked into different treatment options, the treatment management algorithms. Fair enough, but many times we need to answer the questions what people come to us, and especially with the social media, people come to us with a lot of viral videos which goes on. I talk about 2 3 aspects which are common what we are seeing and give a little bit of myths and the truths about them so that you can understand and suggest your patients appropriately about these social media viral videos. There are 3 things what we are commonly what I'm seeing now. One is stem cell therapy for PARC. Many people are misguided, I should tell that, because people have been told that because the dopamine is going down and we are going to give you stem cell therapy and Parkinson disease is going to be cured or stopped. That's a fair enough at a logical understanding because the cells are going down. You are putting a stem cells which produce the neurons which produces dopamine. And if you produce the neurons which produces dopamine, your Parkinson disease should be cured. That is logically true. But this research is going at least for last 30 to 40 years. And till now, we have not hit that eureka moment. The problem is in spite of producing those chemical producing cells, they're not getting the links the way it should happen. I usually give an example of group of friends. Let us say you have five friends together. You are almost born at the same age. You have played together, born together, and working in different professions. And you have type of a bonding which has developed. And let us say at the age of around 50 years, one of them passes away. If I find a person who is like a similar height, similar personality, similar profession, same position, and ask him now he is your new friend, even though he may match to certain of the expectations, but does not match to all the expectations what you had or what the thought process each one of you understand each other. And that is where the lack is happening. Many shops are there across India which propagate stem cell therapies as cure or treatment. And many people have gone there and come back and have seen people after going through that also. There is no cure, let us put it, or no reversal of the disease. People have told, oh, we felt bad. In the newspaper, I remember a newspaper ad was that 40-year-old person cured of Parkinson disease after stem cell therapy. We know that that is not true. That is what is the situation. Stem cell therapy is still only at a research phase. We are trying to understand how it might help. Yes, down the time we may get that eureka moment. Currently, definitely not for treatment based and definitely not for a paid treatment. That's what you need to remember. So that is where the stem cell therapy related myth and understanding remains. Yes, over a period of time, we may get that eureka moment. Second one was one of these Nanavati hospitals video where a person with Parkinson disease was given an injection, and after giving injection, he quickly got up and started moving. Many people interpreted it as cure for Parkinson disease. It was an injection with apomorphine, like I showed you in the videos previously. So any person with medication also after 15-20 minutes they can get up and walk around. They showed what are the benefits. They never told in the video, it was not explained how long the benefit lasts for or who are the patients whom we visit. So basically what it shows is a rescue therapy. Person who is slow and stiff, you give an injection. After giving injection, patient gets up and starts walking around. That's what it is. The apomorphine rescue therapies work for about 60 to 90 minutes. And during this time, you need to expect that other medications will start working. So that's what you need to understand when people come and talk to you about Nanavati Hospital's injection video. Then recently, we saw a newspaper article on 15-minute radio surgery transformed life of a 70-day. Almost they told that after doing the surgery, patient became almost cured. That is what many people were looking into it. But they clearly told that after doing surgeries, his tremors were reduced by 70 to 75% and improving his quality of life. That's what they have told. So this is a lesioning surgeries. So it's as I told about different types of this is like a radiotherapy based surgery. Here what we do is we use a gamma knife, a radiotherapy what we use for cancer patients. We use that, we burn certain part of the brain, and that part of the brain when you burn it, you get the transitionally benefit. The limitation of this gamma knife is when you burn it, the lesion size, you don't see the benefit soon. This may take few days because the lesion changes over few days to few weeks. Okay. And based upon how the lesion size grows, you see the benefits. These lesioning surgery has been there, especially gamma knife for last 25 to 30 years. But it went into a backstage mainly because that the lesion size evolves and sometimes it may be for good, sometimes it may be bad. We cannot predict it. But when the DBS came into the picture, because DBS was more predictable, we can modify it. All these lesioning surgeries went to a backstage. Recently, MR guided lesioning surgery has also come. MRGFS is currently available in India in 2 centers. This is a non-invasive surgery where we put patient goes to the MRI machine and uses ultrasound beam to burn. There, like classical lesioning surgeries, you get the benefit immediate. Most of the time, those symptoms remain constant. Means the lesion size remains constant. It's not like the lesion is growing or changing with some time. However, it's still a lesioning surgeries. Remember, always, most of the time, lesioning surgeries, we only do it on one side. We avoid doing on two sides because both the side lesioning surgeries usually have detrimental side effects like speech, balance getting affected. In MRGFUS, the lesioning size is very small And because of that, they are trying out on bilaterally with potential benefit. We need to see how it will work out down the time, but that is how it is going on. It's a evolution of lesioning surgeries with the time. So these are the three important things which I wanted to talk about, which many people come and ask for you or for me about what to do. We have seen this newspaper article, that newspaper article, or this social media forward has come to us. This is what you'll understand. Finally, to conclude, a whole of this talk is, please do remember that Parkinson disease is a common aging related disorders. It is at a brink of a major outbreak. It has a cluster of symptoms which you call it as non-motor and motor symptoms. Like you remember the tree with the seed, root system, and the plant. Risk factors includes, many people ask why it happens. It's genetic and environmental factors. Clinical diagnosis is based upon the clinical features. Good symptomatic treatment options are available, including medical, surgical, and non-pharmacological management. Slowly evolves over a period of time, and lot of research is going on looking for cure or early intervention. We may not be too far away from personalized care medicine or possibly some disease-modifying therapies. Probably we may get within the next 5 to 10 years. That is my expectation, and let us see what it happens. Thank you. Thanks a lot for giving this opportunity. And I hope that this talk on Parkinson disease gives you a bird's eye view about what is Parkinson disease, what are the different types of Parkinsonian symptoms, what are the different types of Parkinsonian disorders, how the symptoms evolve over a period of time, what are the different stages of Parkinson disease, what treatment options we have, what has to be choose at which time of time, what is the classical algorithm what we use for management of Parkinson disease, and what are the works going on in Parkinson disease in a bird's eye view. Thank you. Any questions? I'll take it up after this. Thanks a lot once again for all the family physicians here who have given me this opportunity. Thank you.